Greetings, family. My name is Dr. Kinney. I'm a clinical pharmacist for Nyan Pharmacy. Our goal is to provide health and drug information to our community and eliminate disparities in health. This topic discussion on colorectal cancer screening is dedicated in memory of our brother Chadwick Boseman. He starred in several films portraying our foundational Black American icons, such as Thurgood Marshall, Jackie Robinson, and James Brown. In his most popular role as T'Challa in Black Panther, he was actually battling stage 4 colon cancer. Throughout the span of his acting career, he displayed Black excellence, the epitome of Black excellence. So one of my most favorite quotes that he had, or that he has, is, "When I stand before God at the end of my life, I would hope that I would not have a single bit of talent left, and I could say, I used everything you gave me." With that being said, let's get to work. Okay, so we'll start with just a few housekeeping things here. The copyright disclaimer under Section 107 of the Copyright Act of 1976. Allowance is made for fair use for purposes such as criticism, comment, news reporting, teaching, scholarship, and research. Fair use is a use permitted by copyright statute that might otherwise be infringing. The content in this presentation is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek advice of your physician or other qualified healthcare provider with any questions you may have regarding your specific medical conditions. The objectives for this discussion, just to review the basics and definitions, to determine the risk factors. We'll focus on prevention as well. The screening guidelines, signs and symptoms of colorectal cancer. We'll review some of the screening tests. And we will also have a summary and review the references as well. Well, the references will be provided for you as well. Okay. So the main parts of your digestive tract or digestive system are your mouth, esophagus, stomach, small intestines, large intestines. The large intestine is also called the colon. All right. The colon's main function is that it absorbs water and electrolytes, produces and absorbs vitamins, form and propel feces toward the rectum for elimination. Okay, so what is a polyp? It's a flat or raised bump of collective tissue, or yes, of extra tissue there. It may have a stalk similar to that of a mushroom. Now, cancer is the uncontrolled growth of abnormal cells. When this uncontrolled growth occurs in the colon or the rectum, it's called colorectal cancer. Most colorectal cancers begin as polyps. They're very common. Actually, in more than 50% of the patients who are 50 years of age or older, when they have a colonoscopy, there are polyps there. However, it's estimated that less than 10% of these polyps will progress to invasive cancer. And invasive cancer is generally a slow process. It takes maybe from 10 to 20 years for this to occur, which is the purpose of why the screening is so important, because in a lot of cases, colorectal cancer can be prevented. Okay, so risk factors. First, we will discuss the non-modifiable risk factors. These are things that cannot be changed, okay? And the modifiable risk factors are things that you can change. You can modify them. So the first non-modifiable risk factor, and we'll put a quote by non-modifiable, is African American, right? So we'll review that a little bit later. It's more common in men than in women. Their risk for colorectal cancer increases with age over 50. That's usually when most patients are diagnosed with colorectal cancer. If you have a parent sibling or child with colorectal cancer, that doubles your risk. If you have a personal history of a previous colorectal cancer, ovarian cancer, irritable bowel disease such as ulcerative colitis or Crohn's disease, high-risk adenomas, diabetes. Diabetes actually increases the risk for colorectal cancer and the risk of mortality from colorectal cancer. Inherited risk are familial adenomatous polyposis. This is actually these patients will develop multiple polyps along the lines of their colon, right? And as we previously said, colorectal cancer begins as a polyp a large portion of the time. So if you can imagine, if you have a colon that's full of polyps, then you have a higher chance to develop colorectal cancer. And a result of that, a lot of these patients they have to have their colon removed by the age of 50 because it puts them at such a high risk for colon cancer. A lot of these patients will progress to colon cancer. Also, Lynch syndrome is an inherited risk. Now, on to the modifiable risk factors, things that we can change, is obesity. This can be measured with the BMI. I'm sure a lot of you are aware of the bias or the racial bias with the BM or body mass index. However, there are other measures of obesity, such as the hip to waist circumference, abdominal fat. Excess abdominal fat actually increases the risk of colorectal cancer also. Eating a diet that is high in red meat and high in processed meat will drastically increase your risk for colorectal cancer, right? Also, a diet that is low in fiber can increase your risk. Having a sedentary lifestyle, not exercising, just not exercising, right? So excessive alcohol use, more than 3 drinks a day, that puts you at risk for colorectal cancer. Smoking, it increases the risk of colorectal cancer, increases the risk of mortality from colorectal cancer, increases colorectal adenomas. Also, these patients who are smokers, if they actually have a polyp or adenoma removed, they're at risk for it to come back. So also, 55% of the colorectal cases in the United States are attributed to lifestyle factors. Colorectal cancer is the 3rd leading cause of death from cancer in the United States. All right, so the risk factor of being African American. We are the highest incidence in mortality, and we are the highest incidence in mortality, right? We have the highest incidence and mortality rate of colorectal cancer, excuse me. All right, this is largely in part to our socioeconomic status. Also, between the years of 2012 and 2016, our incidence rate was 20% higher than non-Hispanic whites and 50% higher than Asian Pacific Islanders. Now, back again to the socioeconomic status. That increases our risk prevalence. These risk factors are obesity, smoking, diet, those kind of those issues. Also, not having access to care and not getting proper screening or not following up with screening when we do have abnormal results. Now, after controlling for differences in risk factors, African Americans are no more likely to develop adenomas or colorectal cancer, but are less likely to receive timely follow-up of a positive screening or test or a high-quality colonoscopy. Okay, so with that being said, let's discuss the prevention. What the previous slide just told us and what the literature tells us is that being African American is not necessarily the risk for colorectal cancer. It's the socioeconomic status. So what can we do to improve our socioeconomic status? Collectively, we can improve our socioeconomic status, decreasing our risk factors for colorectal cancer and other diseases. We can be more aware of what's going on in our communities. Right now, there's a plethora of information to help us facilitate, to help us become economically empowered, right? So one of the things that we can do is have community awareness, what's going on in our communities, such as gentrification. You have Black Channel Films that has provided documentaries on this topic. We can become more socially aware of of our history and learn more about ourselves as people and as foundational Black Americans. There is a documentary, a 5-part series, Hidden Colors, and that's something that you may want to watch. It will be able to help us get on code and adopt a code of conduct where we're supporting Black-owned businesses which support the community. We Buy Black, that is a company that works to empower Black businesses and help them grow. We can become more educated about investing and running businesses and starting businesses. There are several people that are doing that right now and do it on a large scale, such as you have Dr. Boyce Watkins with the Black Business School. You have Earn Your Leisure There is the Wall Street Trapper. I know for certain that the Wall Street Trapper, it walks you through everything very detailed. So I've seen that website. You have the Black World Order, that is 19 Keys, Brother Ben X, Derek Grace, and other people. It's a group of them that work together. So we have, and as also the Fly Nubian Queen, they have a plethora of information about starting businesses and how to level up your business, specifically Lanie Javette. She's a business strategist. We can become more educated about real estate. We have Tony the Closer. We have Tony the Closer. He's someone who does real estate on a large scale. We can improve our credit so that we can have access to capital, and also we can work with each other to help increase our access to capital. Someone who does work with credit is Andy the Credit Guru, and we can make sure that we have life insurance so that when we do transition, that we leave our families in a good place. So those are things that we can do to improve our socioeconomic status. All right. Strengthening Black families is culturally and socioeconomically beneficial. So, building generational wealth. We can also resist gender divide tactics that threaten the well-being of our communities. As far as diet, we can avoid or decrease the amount of red meat that we eat or processed meat, fast food, teach our family good eating habits. We can also meal prep for people that it's difficult for you to necessarily control what you eat all the time. Meal prep is a good idea. Also exercise so you don't fall into that trap of having a sedentary lifestyle. We can meet up with our friends to exercise. We can have lunch break workouts, and we can lead by example and show our children that exercise is cool, that it's necessary, and let it become a part of our life and our family culture. Smoking cessation, very important. When you stop smoking, not only do you increase or decrease your risk for colorectal cancer, but it also decreases your risk for other diseases as well. Now, also, we can limit our alcohol intake. I'm not saying don't drink at all. That's not what I'm saying. But it is very important right now, Black people in America are experiencing healthcare disparities in a large part due to our socioeconomic status. Excessive drinking is contrary to empowerment. We need sober minds to improve our current situation, and in result will improve our health issues. Also, people with healthy lifestyle behaviors have 27 to 52% lower risk of colorectal cancer compared to those without these behaviors. Finding and treating colorectal cancer early may prevent death from colorectal cancer, and also removing polyps is important for prevention. Okay, so why are we screening? Okay, you want to look for colorectal cancer before symptoms occur. It may be easier to treat polyps or colorectal cancer in the earlier stages. By the time symptoms develop, the cancer may have already spread. Now, also, just because your doctor suggests a colorectal screening does not necessarily mean that you have colorectal cancer. However, if you do receive abnormal results, it is very important that you follow up with diagnostic tests as soon as possible to make sure that there's no cancer present. Okay, excuse me. All right, so colorectal screening is it's arranged according to your risk factor. That's going to determine how you will be screened. So it's determined by your colorectal cancer risk factor classification, right? So this is categorized as average risk, increased risk, and high risk. So the guidelines that I will be using to discuss the colorectal screening are from the American Cancer Society. So first we'll start with average risk. These patients do not have a personal history of colorectal cancer or certain types of polyps. They do not have a family history of colorectal cancer. Well, they do not have a personal history, and they do not have a family history of colorectal cancer. They do not have a personal history of irritable bowel disease, such as ulcerative colitis or Crohn's disease. They do not have a confirmed or suspected colorectal cancer syndrome. They do not have a personal history of radiation to the abdomen or pelvic area to treat previous cancer. These patients should start screening at 45 years old with a stool-based test or a visual exam. Patients who are 46 to 75 years old who are in good health with a life expectancy of greater than 10 years should continue regular screening. Between 76 years old and 85 years old, it's based on preference, life expectancy, overall health, and prior screening history. Over 85 years old, it's not recommended. Now, the American Cancer Society does not publish guidelines for patients who are at increased risk or high risk. The U.S. Multi-Society Task Force on Colorectal Cancer does. However, these guidelines they're complex, and you should look at them with your healthcare provider to determine what is appropriate for you. But I'm still going to discuss what is increased risk and what is high risk for colorectal cancer. Patients who are at increased risk, they have one or more family members who have had colon or rectal cancer. And that is going to depend on how they are going to be screened is going to depend on the genetic relationship to the patient and the age the family member was at diagnosis of the colorectal cancer. Patients who have had certain polyps removed during a colonoscopy, these patients are going to generally repeat the colonoscopy after 3 years, and that's going to be, or sooner. That's going to depend on the size, the type, and the number of the polyps, okay? Patients who have had a personal history of colon cancer or rectal cancer, and patients that have had a history of radiation to the abdomen or pelvic area to treat a prior cancer. These are the patients that are at high risk, increased risk. Patients who are at high risk, they have irritable bowel disease or Crohn's disease or ulcerative colitis, if they have a known or suspected to have a genetic syndromes. Okay, what are the signs and symptoms of colorectal cancer? The change in bowel habits, blood in the stool, unexpected weight loss. Now, just because someone has these symptoms does not necessarily mean colorectal cancer. Your doctor will need to provide a differential they would need to do tests to determine differential diagnosis to see what else could be going on. But just to move back into the signs and symptoms, the blood in the stool, that's a red flag. Unexplained weight loss, that's a red flag. Of course, if you have blood in the stool, you're going to go to the doctor, right? Patients that have diarrhea, constipation, anemia, frequent gas pain, constant fatigue, nausea and vomiting, stools that are narrower than usual, feeling of incomplete voiding after a bowel movement, discomfort, pain, bloating, fullness, or cramps in the abdomen. However, it is important to remember that early colorectal cancer does not have symptoms. Excuse me. All right, now moving on to the screening test. There are two screening categories, stool-based and visual-based. They're exactly what they sound like. The first two, the fecal immunochemical test and the Gaiac-based fecal occult test, these tests are going to be done yearly, and they can be done in the comfort of your own home. The DNA stool test can be done every 3 years. Now, the visual-based tests, the sigmoidoscopy and the virtual colonoscopy or CT colonography, they can be done every 5 years. And the colonoscopy, which is the gold standard, it can be done every 10 years. Excuse me. All right, so moving along. The first test we are going to Okay, so the first test that I'm going to discuss is the fecal immunochemical test. Now, this test and other stool-based tests, their rationale is that they are looking for blood in the stool. As the blood vessels in the polyps and colon cancers are fragile, and they're easily damaged when stool passes through the colon. This will result in bleeding, and the amount of blood will be so small initially that you will not be able to see it with your naked eye. That's why it's called an occult blood. So this test specifically uses antibodies to look for blood in the feces. All right, this test does not have any dietary restrictions. And again, this test can be done in the privacy of your own home, and it's done yearly for patients who are at average risk. This is the contents of one of the FIT tests. For the sake of time, I'm not going to go through how to collect the stool sample, but some of them use brushes, some of them use toilet tissue, they use different solutions to help collect the sample, the stool sample. If you have any questions about this, or I can make this available to you in a separate, in a separate discussion, but it's something you can just go online and just Google how to collect these samples. All right, so the next test that we're going to discuss is the Gaiac-based fecal occult blood test. This test uses a chemical reaction to find the blood in the stool. It does not distinguish between bleeding from further up in the digestive tract, right? So this test may also require more than one sample. It does have dietary restrictions, such as not eating red meat 3 days prior to the test. The test may not be able to differentiate the blood in something that you ate versus you yourself bleeding. So you may have a false positive. Also, you should not ingest more than 250 milligrams of vitamin C 7 days prior to the test. It may result in a false negative, meaning that you may actually be bleeding, but the test will not be able to detect it. And that's very important. If you're bleeding, if you're at risk, that's something that you want to be able to know, right? There are drug restrictions for this exam, such as aspirin, NSAIDs, such are non-steroidal anti-inflammatory drugs within 7 days prior to this exam, such as naproxen, ibuprofen. These drugs can actually yield a false positive. And again, this test can be done at home and it can be done yearly. This is an example of, or this is one of the fecal occult, the Gaiac based fecal occult test. This is an example of one of the tests. If you're interested in finding out how the specimen is taken, you can just go online and review that. For the sake of time, I'm not going to go into that one also. All right, so the stool DNA test. The first two bullets here are other names of this test. The rationale behind this test is that polyps and colorectal cancers, they have mutations in the DNA on certain genes, right? Now, the lining of the colon is going to shed regularly. When stool passes through the colon, some of the cells that are being shed is going to be collected on the feces, right? This test also uses the fecal immunochemical test technology as well. So it is going to detect mutations, or it's going to use the DNA technology, and it's going to use the FIT technology to look for blood in the stool as well. The Cologuard is the only test that is available in the United States that looks for DNA and FIT. It also finds precancer and cancer. It can be done in the privacy of your own home, and it can be done every 3 years. This is the contents of the test. If you go to Cologuard.com, you'll be able to see how to collect the specimen. It walks you step by step. Again, for the purposes of time, not going to go into detail about that process. Now, moving right along, the colonoscopy is a visual-based test. The colonoscopy allows you to see your entire colon, right? It can be done less often, so every 10 years. However, it requires preparation as compared to the fecal-based test. Yes, the fecal-based test. And what I mean is, as far as preparation, I'll explain it in a little bit more detail. So you need to review the patient. Well, your doctor is going to review your patient history, look for allergies. We want to make sure that you're not allergic to anything that you're using during the process of having the colonoscopy. You want to know your family history. We discussed earlier that helps determine what your risk is for colorectal cancer. We want to discuss previous surgeries. Have you had any issues with your colon before that your doctor should know about before they start looking around in there? Any bleeding disorders, that's going to be important. Your pregnancy status or your plans to become pregnant, your bowel movements, are you having any issues going on right now? Are you currently not able to pass stools? Have you had issues with anesthesia before in the past, right? If you're going to use anesthesia, that's something that's going to be very important. Any over-the-counter medications that you're taking, any prescription medications that you're taking. Again, aspirin, that's important. It's something that we need to know because you may have a false positive. Some patients may be taking medications to thin the blood. If the doctor is doing the procedure and you start to bleed easily, then that's something that your doctor would want to know. Also need to be aware of what herbal medications you're taking. This exam does have dietary restrictions. You need to have a low fiber diet 7 days before this procedure. Now that's contrary to what we were saying previously about how the importance of having a diet that's high in fiber. The reason for having a low fiber diet in regards to preparing for this exam is that a high fiber diet is going to leave residue in your colon, such as nuts, beans, certain vegetables, carrots, those kind of things. And when you are having the colonoscopy, it may block the vision it may be able to block seeing certain polyps or, basically what's going on in the colon. So you want to have a clear view. Your doctor should have a clear view of what's going on. 1 to 3 days before the procedure, you want to eat a diet of clear food. You can have juice, but it needs to be juice that doesn't have any pulp in it. Broths, those kind of things. Jello, Gatorade, just basically as clear food clear things that you can. Now, the day of the procedure, within 10 days, within 2 hours of the procedure, you should have nothing by mouth. A colonoscopy is also going to require you to have a bowel prep. Excuse me, please. A colonoscopy is going to require that you have a bowel prep. This is going to be an oral liquid medication. You're going to be drinking a large amount of this medication, and it will cause you to have frequent bowel movements. So it's going to be very important that you stay close to the toilet. Your stool will become clear. It may turn like a light greenish color. The skin around your anus or the skin between your buttocks may become irritated. So you will want to use wipes that have aloe in them or vitamin E. If you are having nausea and vomiting from drinking the medication, it's important that you take a break, stop for 30 minutes, and then resume drinking the medication. However, if you just continue being nauseous and vomiting, you need to contact your doctor, right? Also, colonoscopy may require that you have an enema, which is basically a liquid injection into your anus. Okay, so moving right along. Okay, now colonoscopy. This is an outpatient procedure, meaning you're going to have the procedure, then you go home. It's an invasive process, meaning an instrument is being introduced into your body. It uses a colonoscope and a monitor. All right, a colonoscope is a long tube on the head of the colonoscope here on the right side of your screen. Oh, and the colonoscope is about 1 centimeter thick. It's a long, flexible tube. And this colonoscopy uses a colonoscope and a monitor. The video camera that's on the head of the colonoscope will project images to the monitor that your doctor is going to be looking at to see what's going on in your colon. Also, on the head of this colonoscope, there is a light, there's a water jet. We already mentioned there's the video camera, and there is a channel for air or water to come through, right? There is a channel here to introduce instruments such as cutting tools to remove polyps or to help wash away certain areas or things that may need to be removed to see more clearly what's going on during the colonoscopy. Now, drugs. You may receive sedative drugs to help you relax, a local anesthetic to numb the area, or a general anesthetic to just make you fall asleep. Some patients don't want to remember it. Some patients may want to know exactly what's going on, but that is optional. You have a choice in regards to that. Now, let's see. Now we are moving closer to the procedure. All right, so we're getting closer to the procedure, the process. So, okay, so you will get on the table, you will lie down on your side, bend your knees, and the colonoscope will be lubricated and it will be injected into your anus and then pass through your entire colon, as you can see here. And here's the monitor that your doctor will be viewing the insides of your colon, right? So it's going to come here and it's passed all the way through the end of your colon. Now, during this process, while the colonoscope is being passed through your colon, air is being injected into your colon to expand the area, to give your doctor a better view of what's going on inside, to inflate the bowels, right? There's going to be two views. There's a view going in and there's a view coming out, all right? Now, if polyps are seen during this process, your doctor will remove them and biopsy them to make sure that there's that cancer is, to determine if cancer is present. The risk for this procedure it's usually minimal, but it includes infection, perforation to the colon, and having an allergic reaction to medication that is being used, right? Now, after the procedure, your doctor is going to monitor your vital signs to make sure everything is fine before you discharge, right? You also may have a little bit of blood in the stool after this procedure. Within 24 hours of this procedure, you should not operate any heavy machinery. And also, you want to ask your doctor when your results are going to come in. And this procedure can be done, or this procedure should be done every 10 years for patients who are at average risk for colorectal cancer. We'll review that. We'll come back to him a little bit later. All right, so now a CT colonography. This is another visual-based exam. It does have dietary restrictions, the same as a colonoscopy. It has the same bowel prep as a colonoscopy. It is an outpatient process. It's minimally invasive in that it's minimally invasive in that the only reason that you will have something introduced into your body is just to fill your bowels with air so that it can expand and the insides of your colon can be seen. That's the reason. That's why it's minimally invasive. This procedure uses a CT scan and a computer monitor. What happens is the CT scan is going to generate 3D images onto a monitor, which will be seen by your doctor. This procedure usually does not require drugs unless someone is anxious about being into the CAT scan machine. And I'm going to play a video to just show you a little bit more to show you how this procedure occurs. Now, the risk for this procedure is low dose radiation. Also, with this procedure, if polyps are present, you're not able to have them removed. You have to have a colonoscopy to have the polyps removed. This procedure can be done every 5 years. Okay, so we're going to just change gears for a minute. So just bear with me a few seconds while I pull up the YouTube video. Second. Screen. Toolbar. Okay, so first let's start with the virtual colonoscopy. No, let's start with the colonoscopy, traditional colonoscopy. All right, this is Dr. Daryl Gray. He is a gastroenterologist, and we're going to see hold on, let me make sure I shared this. Yeah, okay, it is shared. Okay, so we're going to see an example of a live colonoscopy being performed. If you're squeamish, this is something that you probably would not want to look at. So just putting that out there before we get there. So 7. Right here. Okay, so this is, right now we're looking at a polyp. He is making it a little bit more visible so that we can see it. This is what they look like, right? So in this video, he actually, I think I recall this video is one of where the polyps were removed. But anyway, so this is just, so that you have a visual perspective of what's going on. So I'll stop it here. Okay, so we're going to stop sharing this screen, and now we're going to look at what a CT colonography looks like. No. Wait a minute. Sorry, family, just bear with me for a few more seconds. I want to make sure that you're able to see this process before you have the colonoscopy. You know what is going on, okay? Show it in Chrome. Visuals. Okay, this is Dr. Cecilia Brewington. She is an expert in this field of the virtual colonoscopy or visual colonography, and I believe it's around second 26. You're going to see the patient going into the CT machine, and these are the 3D images that are being projected back to the screen so that the doctor can view them. And this is the patient going into the machine. This procedure is relatively fast or relatively short. I believe they take maybe a few images from different directions. Okay, so I'm going to close this back out now. Go back into the presentation. Okay. All right, so moving right along. All right, so the next visual test that we're going to discuss, or that I'm going to discuss, is the sigmoidoscopy. It's you don't have to do it as often. This test is done every 5 years. It requires a little bit less preparation than this should be less, not more preparation. As by that I mean you don't necessarily have to do a full bowel prep. Generally, your doctor may tell you just take a laxative and you may have an enema versus during the full bowel prep, right? And you don't have the same dietary restrictions. It's not as in depth, okay? But you're still going to need to give a patient history. And this is an outpatient process. It is invasive, being that there is going to be an instrument introduced into your body, the sigmoidoscope. The doctor is going to use a sigmoidoscope and a monitor to view what's going on in the colon. As you can see, this instrument, it stops here, does not view the entire large intestine, right? The limitations with this is that if there are polyps in other areas of the colon, you're not able to see them. So that's the limitation, right? And it's generally going to be the same procedure. You're going to lay on your side. You're going to have the bowel inflation, two views, one view in, one view on the way out. If there are polyps seen, the doctor is going to remove them and biopsy them and to determine if there is cancer present. The risks for this procedure are going to be similar to that of the colonoscopy, but it's not as the risks aren't as high because you're not examining the entire colon, right? The post-procedure care is going to be the same as that of colonoscopy. Now, just a quick recap. Patients who are 45 years of older should get screened. If you are at high risk or increased risk, you need to get screened sooner. Abnormal screening results should be followed up with diagnostic tests. Also, to improve our socioeconomic status, we need to adopt an empowering code of behavior for our community. We need to eat healthy and exercise. We need to avoid harmful risk factors, or if we do have to, engage in these risk factors, of course, try and do them in moderation. Also, apply this information and share it with our community. I hope that this discussion was informative and that it helps you. Please share it with someone that you know who may be at risk, or just share it with whoever, because you never know who needs to hear it. Please let me know what other topics you are interested in discussing. If you have any other questions in regards to colorectal cancer, such as colorectal screening or colorectal cancer, I did not address the drugs here, but I am a pharmacist. So if you have questions about that, please feel free to reach out to me, or you may contact me in the comments, DM me, or however. Okay. So please like and share this information. I'm going to provide my references here. Just one second. Oh. All right, family, please like, share, and subscribe.